Good morning, everyone. Wendy here from Broad Garden. Glad you could all join us today. Our second session here of Breast Talk. October, as everyone knows, Breast Cancer Awareness Month. We've been talking a lot in the shop. Several ladies, just different aspects of breast cancer, and we're so very fortunate this morning and honored to have Dr. Lisa Guerra with us here this morning. To talk more in detail, educate everyone a little bit more on breast cancer. Big important topic, of course. So first, without further delay, Dr. Guerra, tell us a little bit about yourself.
Sure. Well, thank you so much for including me in this month's festivities. I'm Dr. Lisa Guerra. I'm a breast surgical oncologist with the Memorial Care Cancer Institute at BreastLink. Kind of got my start actually in Illinois. I did my undergraduate training at University of Illinois at Urbana-Champaign, and had, from when I was a young girl, thought I wanted to be a doctor. Did go to medical school at University of Illinois at Chicago. And then during my medical school training, it occurred to me that surgery may not be a bad field for me to go into. And so I stayed in Chicago at the University of Illinois at Chicago for general surgery training. And during that time, realized that perhaps I wanted to eventually have a good balance between work life and home life. And breast surgical oncology fellowships were just kind of getting a foothold around that time frame. And so I ended up pursuing breast fellowship training at the University of Southern California and LA County hospital systems for a couple of years before I ended up being wooed to go to Hoag Hospital as a private solo practitioner, where I was at from 2008 until 2015 when I was hired as a salaried employee with benefits in 2015 by BreastLink, and more recently in 2021, the practice was accrued by Memorial Care System. So I see patients within Orange County and have privileges at the Memorial Care facilities within Orange County at Orange Coast, as well as at Saddleback, and have retained privileges at Hoag. And so I have been in Orange County seeing our Orange County patients, as well as individuals from across the country and worldwide since 2008.
That's amazing. That's amazing. Now, many of you know that have been in the shop already that I also work in the operating room, a surgical assistant or technician or technologist. They have so many names for us now, and have worked with Dr. Lisa Guerra many times, and so honored. She's an amazing surgeon. Amazing in the OR, very skilled, and which is a big reason of why we asked you to be here today. A lot of trust, I've already seen, the magic that you do in the OR. It's amazing. Having said that, talking about surgery, let's actually take a step back before we even get to the surgical side of things and talk about what is breast cancer. I know statistics change all the time, but I'm reading, what is it, 1 in 8?
1 in 8 women in the United States will develop breast cancer at some point in time during their lives. And cancer is really just an abnormal growth of cells. So really, unfortunately, our 2 top risk factors for breast cancer, we honestly have no control over. Number 1, being born female, and number 2, aging. And so 70 to 80% of breast cancers actually have nothing to do with our genetic makeup. It's literally just a cell that made a bad copy of a cell, but your body didn't recognize it was a bad copy. It thought it made a good copy, and it allowed that cell to make more copies. And so that kind of unstopped progression of producing these abnormal cells eventually can lead someone from having something that may be more of a high risk precancerous sort of finding, which the more common location for those cells to originate would be within our ductal system. So even taking a step back from there, the breast itself has multiple structures. But the big main structures that we typically take into consideration are our breast lobules, the lobules essentially help to form milk, and the ducts that are essentially the transport unit between the the lobules that make the milk out to the nipple itself.
Mhm.
So the ducts themselves are supposed to have just two cell layers, an outer muscle layer that helps to push or squeeze milk through the ducts, and then an inner lining layer we call the epithelial layer.
Mhm.
And when the epithelial layer, just with the aging process, it can just form more cells than what it really needs to have. And if those cells are kind of normal cells and there's just more of them than we need, that's completely a normal process. That's benign, nothing to worry about. But it's when one of those cells makes a bad copy that we run into trouble. So if there's too many of those bad copies of cells, we initially have something referred to as atypical ductal hyperplasia, and that's a precancerous finding. That the best way for us to really detect that process is with a mammogram. And I know we're going to talk a little bit more about mammograms
Definitely.
as well, because calcifications are something that we can see on a mammogram, just looks like little white dots on a black-gray background of breast tissue. And granted, most calcifications are nothing to be concerned about, but calcifications that are new or increasing in number can kind of give us a red flag that there might be something that's amiss.
Okay.
But if we get enough of those atypical cells, eventually we reach a threshold, we stop calling it atypical and we start calling it an early form of breast cancer. The very earliest form of breast cancer is referred to as ductal carcinoma in situ, which is abbreviated as DCIS. And that type of process, if we kind of break down that term, means that we now have cancer cells, but they are located on the inside of those breast ducts.
Mhm.
So the only place in our bodies that have breast ducts are our breast.
Right.
We don't have breast ducts in lymph nodes or other organs of the body. So that's a type of process. It's a threat to the breast, but it's not a threat to anyone's life.
Mhm.
But unchecked, unrecognized, if those cells are allowed to mature, then eventually they may gain that skill that they need to be able to break outside of the breast duct and into the surrounding tissue. So cells that are able to invade through the wall of that duct or infiltrate through the wall of that duct, we refer to as invasive ductal carcinomas or infiltrating ductal carcinomas, two terms we can use interchangeably.
Mhm.
But because it has that property that it is able to kind of move through things,
Mhm.
unfortunately, it could try to move through things like into lymphatic channels,
Mhm.
which could then try to carry it to places like lymph nodes and or into blood vessels that could try to carry it into other places in our body. So our ductal cancers tend to be our most common type of cancer, but it's really just originated as an overgrowth of an abnormal cell.
It seems so basic when you talk about it in those kind of terms, but it's not. I mean,
Yes, I mean, if we think about our own bodies, my knees are not nearly as good as they were when I was half my age.
oh yeah, me too.
Things tend to wear out with time, and it's
Right.
the same thing as that kind of checks and balances system that our body goes through. More times than not, it's able to recognize if it made a good cell or not.
Mhm.
But when it loses that ability, it's like it didn't put its glasses on, then that's where things can kind of run amok.
Right. And you had mentioned mammograms.
Yes.
So talk about a few different ways to detect it, right? So even
Correct.
before we get to that stage, a lot of times, you go your annual exam or something, and you're self-check and self-checking your own breast and your own. How effective is that? And how should everyone
Right.
be doing that?
Right.
And how often?
That's a great question. And the answer has really changed over time.
Mhm.
It used to be that we taught individuals how to do a self-breast examination.
Mhm.
And it was a way of kind of being able to monitor what is normal for an individual, what's not normal for an individual. But they've kind of modified that a bit to more of a self-breast awareness concept.
Mhm.
So we don't necessarily teach individuals how to do their own exam.
Mhm.
Part of the reasoning is that some patients, that makes them extremely anxious.
Right.
They feel like, oh my gosh, there's something that's going on everywhere, and I don't know what is normal and what's abnormal. And then they stop evaluating themselves altogether.
Right.
So what I generally share and encourage individuals is to just kind of know what's normal for you. If your background breast tissue is a little on the lumpy, bumpy side, that's okay.
Mhm.
But if something were to stand out that seemed different,
Mhm.
then that's what we want patients to pay attention to.
Right.
So that can be something that feels more like a piece of gravel in the breast tissue, as opposed to something that might be a little bit more soft and round.
Mhm.
If they notice some sort of a change to the skin of the breast, there's an area where the skin looks like it's pulled in and it's not symmetric with the opposite side.
Mhm.
And that can happen also to the nipple itself. If the nipple starts to pull in when it wasn't pulling in before.
Mhm.
If there's a difference in the pigmentation in a certain area of the breast, then that might be cause of question or concern. So certainly kind of knowing what's normal for you,
Mhm.
combined with also recognizing what's going on with that individual's family. So having an idea about who in the family may have had a breast cancer diagnosis, who in the family may have had other types of cancers, because sometimes that can also influence what a physician might advise for that individual as far as their overall surveillance is concerned.
Okay.
And so as you made mention of, and I'm going to go ahead and transition into mammograms.
Please do. Please do.
Screening mammograms are considered to be our workhorse, if you will, of breast imaging. The general recommendations would be that if someone is at average risk of breast cancer, which is the majority of individuals, that really we start imaging typically at age 40. Now, this whole age of starting imaging has been a bit controversial. Different societies had come out with different recommendations about when to start. And even some that previously said 50 to start have changed their mindset and have reverted back to starting really at age 40.
Okay.
There's still some differences of opinion about the frequency with which we do mammograms. I see breast patients all week, multiple times a day. I'm a terribly biased individual, but my general recommendation is that individuals have their mammogram every year.
Mhm.
One mammogram every year to help and identify and confirm stability. You know, with COVID, I think we had a lot of individuals that may have been concerned about going to healthcare facilities, and rightfully so. And even some of the imaging facilities were saying, if you're coming in for routine screen, we don't know about what's going on with this COVID business.
Right.
But we did see delays with individuals coming in for their screening examinations.
Mhm.
And unfortunately, we were seeing breast cancer diagnoses that were a little farther along
Okay.
than what we were more typically seeing.
Uh-huh.
So there's still that benefit from doing that annual mammogram. Mammograms typically entail looking at the breast using an X-ray. They squish your breast in two directions, top to bottom, and then side to side, kind of on an angle, to be able to identify what's going on within the breast itself. And what they're really looking for is areas of asymmetry, things we see on one side that we just don't see on the other side.
Okay.
So if they see an abnormality, then they'll typically ask an individual to come back for a diagnostic study. Diagnostic study, they're trying to diagnose, why does this particular area look different than in the opposite breast?
Okay.
And in some cases, they'll do that diagnostic workup and realize, you know what, the something we saw is actually a nothing. It may have been that breast tissue kind of got pushed down and folded on itself
Okay.
when they did the mammogram, but with the additional views, when they were able to kind of splay that tissue out more,
Mhm.
they may have recognized, oh, you know what? the tissue looks normal now. They may even do an ultrasound, which is another imaging modality, just to help improve, is there any sort of lump that's seen within that breast?
Okay.
So more times than not, mammograms will be normal.
Mhm.
Or even if an individual is called back to have additional imaging, more times than not, it will still be something that's not of great concern.
Mhm.
But if there's any doubt, question, then they may either do one of two things. They may either say, you know what, I'm concerned enough that I'd rather have some tissue to look at under the microscope to
Okay.
know if it's something that we should be concerned about or something that's okay.
Mhm.
Or if it's something that they haven't seen before, but they think that the chance of it being cancer is less than 2%, they'll say, come back. Let's have you come back maybe in 6 months.
Mhm.
Let's take a look at it again, just to make sure it has not changed in some way, shape, or form.
Okay.
Radiologists usually love to see stability of imaging for 2 years
Okay.
before they're comfortable in saying that that particular finding is normal for that particular individual.
That makes sense. It's interesting that you're talking about, coming in a little bit younger, starting at more of age 40. And I'm sure you've seen much more than I have, even here in the shop, ladies coming in post-surgically and much younger.
Yeah.
I mean, much younger
Yeah.
ladies. And, it's not necessarily an issue of, oh, I'm only 30, so I'm safe, or I'm,
Right.
like you said, really monitoring yourself, being aware of your own body.
And that's a
and
great
changes.
great point. So in my patients that may be less than 40, they're not in that time window to start doing breast imaging. It's not that they shouldn't know what's going on with their breast tissue. Typically, once an individual is in their 20s, 18 to 20, that's when we start wanting them to at least kind of be aware of what is normal for them or abnormal for them. And so I generally will tell any premenopausal woman that if you feel a lump and it doesn't go away within one menstrual cycle, so you've had your period, it's about, it started about a week ago, it's at the end and it's still there, ultrasound would typically be a good idea to help and look at that particular area. Even if an individual is not yet 40, they should still have it checked out. More times than not, for a younger individual, it will be benign. But you and I both know, and we've seen that there are individuals, unfortunately, that may be diagnosed with breast cancer at an age less than 40.
Mhm.
So that also goes along with recognizing and understanding an individual's personal and family history related to breast cancer as well. I made mention 70 to 80% of breast cancers have nothing to do with our genetic makeup, but that does mean that there's a minority of individuals that can.
Right.
And so we have more access now to doing things like genetic testing than we did in the past to help and identify, is there something in an individual's DNA that could otherwise predispose them to being at a higher risk? So for individuals, for instance, that have been diagnosed with breast cancer at a relatively early age, and we consider relatively early to be an age less than 45 to 50,
Right.
an individual with ovarian cancer at any age, an individual or family that's had both breast and ovarian cancer, a male patient or relative with breast cancer. And
Wait. So men can also get
yes,
breast cancer?
they can. They have
Okay.
breasts.
Hold
If
on.
you have
Hold
breasts,
on.
you can get breast cancer.
Okay.
So
Men,
yes.
should they be checking themselves as well?
A general awareness is always good. The risk of male breast cancer is less than 1%. It's not a common occurrence, but men with breast cancer do have a higher chance of having a genetic mutation.
Okay.
So that's one of those factors that we do look at. Yes. An individual that's had more than one breast cancer themselves, those of Ashkenazi Jewish descent with breast or ovarian cancer at any age, individuals or families that have 3 or more individuals on the same side of the family within 3 degrees of relatives that have had breast cancer, or those with a more aggressive breast cancer, what we refer to as triple negative breast cancer diagnosed at any age, those are typically individuals that we might more strongly consider or favor doing genetic testing for. Health insurance plans cannot discriminate against an individual for having genetic testing.
Right.
However, there are concerns that some of the life insurance plans may.
Okay.
Now, individuals that have had a breast cancer diagnosis already, the life insurance plans may discriminate against you for having a cancer diagnosis. And so it's those individuals that have had a diagnosis of cancer that are typically the best individuals to test.
Mhm.
But we run into situations where perhaps those individuals, unfortunately, are no longer with us.
Right.
And so then that family member might be interested in learning a little bit more about what that does for their risk.
Mhm.
So genetic testing is typically a blood test or a saliva test, and they're helping to identify if there's some sort of a mutation. The
Okay.
best studied genetic mutations are mutations in the BRCA1 and BRCA2 genes, which got a lot of press when Angelina Jolie came out talking
Right,
about her
right.
bilateral mastectomies. But as we mentioned at the very start, the average woman's risk of breast cancer in the United States is that risk of about 1 in 8 women. It's
Mhm.
about a 12.5% lifetime risk. In Orange County, the risk is a little higher, about 1 in 7 women, or about a 14.3% risk. But we consider average risk to be a risk that's less than 15%.
Okay.
Now, that's as opposed to BRCA mutation carriers. They can have an up to 87% lifetime risk of breast
Oh, wow.
cancer, which is obviously a lot more
Big difference.
than that less than 15% risk. They can have an up to 60% chance of developing a second breast cancer, whereas the average woman's risk is closer to about 10%. And their risk for ovarian cancer can be as high as 45 to 60%, whereas the average woman's risk is rare.
Mhm.
So if we're contending with those sorts of statistics, we do make different recommendations and considerations.
Absolutely.
Those individuals actually have a recommendation to start annual MRI surveillance starting at age 25.
Wow. Okay.
They incorporate annual mammograms into their imaging routine at age 30, so long as they have breasts still with them.
Right.
And those are actually individuals that carry recommendations to more strongly consider having both of their ovaries and their tubes removed as early as 45 to 55, and sometimes even earlier, depending on the ages of diagnosis of ovarian cancer in those individuals. Sometimes they may have recommendations even starting into their 30s or earlier. And so these are individuals that are kind of thrust into situations where they might need to be thinking about family planning
Right.
and how much significance their breasts are to them during their lifetime.
Mhm.
And so these are situations that we treat a little bit differently.
Of course.
Now, the majority of individuals that may have genetic testing will not have a genetic mutation. But if they have a first-degree family member, parent, sibling, or child that's had breast cancer diagnosed at an age less than 50,
Mhm.
we recommend that they start imaging surveillance 10 years younger than that earliest age of diagnosis. So if my mother had breast cancer at 48, then I would start annual imaging at age 38.
Okay.
So you're mentioning about, how early do we start? Some people may be diagnosed at earlier ages. Those are individuals that really should have a good understanding of kind of that family history aspect of things.
Yeah.
Now, because most individuals don't have a genetic mutation, as a breast surgical oncologist, as a breast specialist, I also might look into what an individual's overall lifetime risk calculation is. So we mentioned that average risk is at risk less than 15%.
Mhm.
Our average recommendations, annual mammogram, annual exam by a clinical physician,
Uh-huh.
nurse practitioner, PA, or physician's assistant. But if an individual has a calculated lifetime risk of breast cancer that's over 20%,
Mhm.
those individuals are considered high risk.
Okay.
And they would qualify for both annual mammogram and annual MRI.
Okay.
Now, MRI is different than mammogram.
I was going to ask,
Yes.
what is the difference? What's the And also, is there any risk, is there any downside to having the mammograms? You said X-ray, right? Is
Correct.
there any downside to having that exposure to the radiation
Great
every year,
questions,
every year?
great questions. So mammogram, it does have a small amount of radiation exposure associated with it. As we age, essentially our tissues become more hardy. There's less influence of that radiation exposure as we age. It's the greatest concern when an individual is going through development.
Okay,
So teens and 20-year-olds, we're not typically recommending mammograms for. Even individuals with BRCA mutations, we're not recommending mammograms that early.
okay,
So after an individual's breast development has finished, that radiation exposure to them should really be kind of a moot point
okay,
in the grand scheme of things
Okay.
when we're looking at overall health benefits and risks.
okay,
They use the examples that if you lived in Denver for a year, the ambient exposure, radiation exposure from the sun that you might get in a year
Uh-huh.
is about what you might have from a mammogram.
okay,
If you were to take a long airplane trip, you're up in the air, that also could give you radiation exposure.
okay.
So
So this is very minimal
Yes.
concern. Okay.
absolutely. So we feel like the benefit
Mhm.
far outweighs the risk in that sort of situation.
Okay,
Now, we've mentioned a couple different imaging modalities. Ultrasound uses sound waves, so there's no radiation exposure associated with it.
okay,
But it can be a little like finding a needle in a haystack. If you don't know where to look, you could miss something small or subtle. So it's
okay,
a great modality to look at lumps to help identify, is it fluid filled like a cyst, or if it's solid? If it's solid, does it have really nice smooth borders to it, or is it a little bit more irregular where we might be more suspect or suspicious?
Mhm.
It's a great tool for looking at lymph nodes and the architecture and size of those lymph nodes and comparing lymph nodes within the armpit from one side even to the other side.
So
But
it's more of a pinpoint
it's a
area.
great
where-
test to, if you know where to look.
Okay, but
but-
mammograms more the full picture.
Correct,
of it.
correct. There are screening ultrasounds that we can do to help just look through the breast tissue,
Okay. Mhm.
but we do need to recognize that there can be some limitations
Okay.
with that type
Okay.
of study. So we do advocate it for some, but not for all.
Right,
In individuals that qualify for MRI, MRI relies on blood flow patterns through the breast to be able to identify areas of concern.
okay,
Breast cancers have a tendency to build their own blood supply. So if
Okay.
you give a contrast dye, meaning you do have to have an IV placed for the examination,
Mhm.
it can cause areas of cancer to light up.
okay,
Now, it can cause other things to light up also that may be of no consequence to us. But what we're trying to identify is areas of asymmetry, things we see on one side that we just don't see on the other side.
okay,
So that type of study does require an injection of a contrast agent and an IV. It's considered a little bit more invasive because of that.
Mhm.
And so that's why not everybody qualifies for that.
Mhm.
Some have had concerns about the gadolinium contrast agent that is used for those MRI examinations.
Okay.
An MRI to look at the breast tissue is useless without it.
Okay.
So if someone figures, oh, can I just do it without?
No, there's no point.
Not a great idea.
Okay,
The only exception to that is individuals with breast implants.
okay,
Non-contrast MRI has special sequences that can be run to help identify the integrity of the implant. Is it ruptured or is it whole?
okay,
But you need the contrast agent to actually look at the breast tissue proper. That gadolinium contrast has, there were some studies that were put out that said in cadaver studies, they found deposits of gadolinium in the basal ganglia of the brain. So that got people worried.
Right.
You know, what is that doing to me?
Mhm.
They haven't linked it to doing anything to anyone at this point in time, but they also, with that recognition, have identified that just like we have different brands of ibuprofen,
Mhm.
like there's Motrin, there's Advil, we have different brands of gadolinium.
Okay,
And so typically for breast imaging, they use a brand of the gadolinium that should not cross the blood-brain barrier.
okay,
So it really shouldn't have the risk of going into the brain. And those individuals that are having MRIs are already felt to have an increased risk of breast cancer.
mhm,
So we would say that the benefit of that MRI and using that contrast again would far outweigh the risk
right.
that's involved.
No, that makes sense, absolutely.
But yeah,
because
they're kind of like our fork, knife, and spoon of breast imaging. Individually, they have their own strengths and weaknesses, mammogram, ultrasound, MRI, but when used in combination, they give us kind of our most complete picture.
Got it. So if something is found and something is a concern, let's say you've done your mammogram, found something, came back, did a biopsy, now you found cancer cells. Now what's the next steps? What do you do? What happens?
So most individuals will be referred to an oncologist of some kind.
Mhm.
In the breast cancer arena, we actually have 3 oncologists that individuals might be seeing, 3 separate doctors, each with their own role in that cancer treatment.
Yeah.
You have an individual like me, we have breast surgical oncologists. Our role in the cancer spectrum is we help treat cancer through the use of surgery. We cut things out. But then we also partner with radiation oncologists that help treat cancer through the use of radiation therapy, and medical oncologists that help treat cancer through the use of medications.
Okay,
Most commonly, when we think about medications, we're oftentimes thinking about things like chemotherapy, as well as a class of medications I tend to call hormone blockers, although their technical term is really endocrine therapy.
okay,
Most individuals with a new breast cancer diagnosis will be referred to typically either or both a breast surgical oncologist and or a medical oncologist. As a surgeon, I like to look through what that individual has had done up to that point in time.
Mhm.
So they may have had mammogram, ultrasound. We may be recommending an MRI for a new breast cancer diagnosis to fully identify what's the extent of that process, how much tissue are we worried about,
Mhm.
and some different properties of the cancer. So we can look at things like the grade of a cancer. That has to do with kind of how close to normal those cancer cells look and behave. A grade 1 cancer is less aggressive. A grade 3 cancer tends to have a more chaotic pattern to their growth. They might be of varying shapes and sizes, and they may be making new copies at a faster rate.
Okay,
We also look at what we call prognostic markers. These have to do with kind of what's driving the cancer. There are many cancers that are fueled by hormones. So essentially, they use estrogen and or progesterone, like my car uses gas.
right,
I put gas in my car is able to run.
right,
I give certain cancers hormones, it can cause them to be able to grow and to thrive.
okay,
So we look at estrogen receptor and progesterone receptor status as a means of helping to identify if that cancer is fueled by hormones, if it's hormone receptor positive.
okay,
The other prognostic marker that we typically look at is something called HER2/neu. HER2/neu is a type of growth protein. We all actually have it to some level, but if that cancer is overexpressing it, if it's amplified or positive,
mhm,
it signifies that cancer is a faster growing cancer.
okay,
We treat faster growing cancers more aggressively. And so those are cancers that benefit from things like chemotherapy, as well as dedicated medications that go after the HER2/neu aspect of the cancer.
okay,
So for more aggressive cancers that we might find really need and benefit from chemotherapy, there are many situations where we might refer as a breast surgeon for those patients to talk with a medical oncologist about potentially even taking medications before we ever take them to the operating room.
okay,
That worries some individuals because they say, why are you keeping my cancer in me?
right,
But the goal is that if you still have the cancer in you, you can check to see, are these medications working?
uh-huh,
You know, if you have to go through chemotherapy, which most individuals consider to be a more aggressive approach for cancer treatment, but some people certainly benefit and need. But if you still have the cancer there, you can check to see, are the medications working? Because if the medications are working, that tumor should be getting smaller.
Okay.
So something that might have felt big in the breast should be getting smaller. If someone had cancer in lymph nodes, we might see those lymph nodes return to more of a normal architecture.
Okay.
So we can literally see, are the medications working? In some cases, if it's things that are kind of too far back in the breast or a little harder to see, we can do things like ultrasound or additional imaging periodically to check to see, are we getting a response from those medications?
So once you begin the medication, typically, I know it's going to change with each individual. Typically, how quickly would you know that there is any result happening or not?
Great question. So it's different depending on an individual's circumstances. Chemotherapy drugs, we tend to see a faster response. So typically within 1 to 2 doses of the medications, we might already see that there's been a response. Different chemotherapy regimens may be given at different frequencies. There are some that might be getting a couple medications every couple weeks, followed by 12 weeks of a different medication. There are some that might just get 2 chemotherapy drugs every 3 weeks for 4 to 6 doses of the medications. And others that might get 3 to 4 medications that might be given every 3 weeks for 6 doses. Yet others that might get weekly dosing of medications for 12 weeks. But generally speaking, within anywhere from 2 to maybe 6 weeks, we can see that there's already been a change that's been happening.
Or not, right?
Correct.
It's not working.
Correct. So that would be more unusual, but in that sort of circumstance, then we have to be nimble, right? We have to change our plan, whether that be to change the medications that are being used, or whether that might be to go ahead and proceed forward with surgery, take the tumor out, and do additional testing on the tumor to help and identify, are there different medications that may be better suited for treating that particular process.
Okay. So now let's say we've moved on to that stage and now we're, decided that surgery is the best option. Let's go ahead and remove it completely. I know everyone will have different reasons for, what they decide to do with their surgeon after full explanation. But let's say maybe you had something only on one breast, and let's say, it was going to be a full mastectomy, but maybe the other breast is okay. At what point do you decide, is it more preemptive to go ahead and take both? Do you just take one? Is there a reason for either, or is it just purely appearance, or is there a medical side, something that would have someone remove both?
Of course, there's a medical side. So it really does depend on the individual situation and scenario. Most individuals will not have a genetic mutation, so the risk of them developing another breast cancer in their lifetime on average is going to be about 10%. Now, 10% is lower than the risk potentially of developing that initial cancer. So most individuals will not develop a subsequent breast cancer. The decision about doing something to the opposite breast then becomes more of a personal situation. So, typically individuals do have the option of either lumpectomy, identifying and removing the area of cancer and a normal rim of tissue around it, versus removing as much of that tissue as possible. Mastectomy, we are generally trying to remove up to essentially where your collarbone sits, down to the fold under the breast, from the sternum out to the side. Technically speaking, it's not 100% of the tissue. So you still leave behind skin of the breast, as well as a very thin rim of tissue underneath the skin surface for the purpose of maintaining the blood supply or circulation to the skin. So we really need to make sure individuals that are interested in doing 1 or 2 mastectomies want to do so for the right reasons. So for instance, some individuals might say, well, just do mastectomy. I never want breast cancer again. It sounds great in theory, but in practice, it's not always the case.
Okay.
Mastectomy can help to decrease the risk of breast cancer coming back in that same breast by about as low as we can get. In the first 10 to 15 years after surgery, that risk may be between 1% and 4%. So it's a low number, but it never goes down to zero. So if they want to do mastectomy for the goal of eliminating their risk of breast cancer, they would be potentially disappointed with that. Now, even lumpectomy and radiation, that 10 to 15-year risk of breast cancer coming back may be anywhere from less than 5%, which is the exact same as mastectomy, up to maybe 10%.
Okay.
So the risks may not be as dramatically different as some people might expect. And some people think that during the course of an individual's lifetime, the risk of breast cancer coming back after mastectomy could be as high as 10%.
Okay.
Removal of both breasts is linked with a 90% risk reduction. It's the most risk reduction we can offer to an individual, but it just never is a 100% risk reduction. I have some people that tell me, well, just do mastectomy. I want to live as long as I can. If I had two of that individual, one did lumpectomy, one did mastectomy, both live the same amount of time. There's no difference in the overall survival. You don't live a day longer from doing a bigger operation. And then some people think that they might be able to get out of things like chemotherapy if they go really big with their surgical approach.
Okay.
The determination on medications honestly has nothing to do with what we do in the operating room. It's really the behavior and biology of that tumor that helps to determine medications.
Okay.
So I like for them to at least have that underlying knowledge base before they're talking about mastectomies in general. Now, the other consideration has to be what some people, especially here in Orange County, we have a lot of augmented individuals, a lot of breast implants out there. But reconstruction following a mastectomy is very different than if we're talking about doing a breast augmentation. If you have breast augmentation, you still have your own breast tissue to essentially kind of hide and cover up that implant. So it may be a little less obvious that you have an implant there.
Right.
The goal of plastic surgeons with mastectomy and reconstruction is honestly that you look good in clothing, that nobody would know that you had a mastectomy and reconstruction in clothing, but naked may be a different matter. So I use the example, if I put a book underneath the paper at the doctor's office, you may be able to see that clearly that is a book underneath the paper. And that can be how mastectomy and reconstruction may look when an individual's naked. There's not a lot that's hiding it, so you might be able to see that reconstruction a little bit easier.
Okay.
If I put a book underneath my very nice comforter on my bed, it may be less obvious that there's something that's going on there.
Right.
So naked, you may not be quite as happy with how the breast may look as compared with in clothing. Other things have to do with sensation to the breast. So even when we do things like nipple sparing mastectomy, we save 100% of the skin of the breast. Your nipple is kind of like a hood ornament for your car.
Okay.
I would prefer it if I had a nice little Jaguar on the front of my car. That would look beautiful. My Hyundai works perfectly well for me. It's just fine. But it's really, my H is not doing anything for my vehicle. So it's the same kind of thing with a nipple sparing mastectomy. The nipple might be there and it might be great to kind of see that it's there, but it's not functional.
Okay.
So if someone really loves their nipple stimulation, we cannot promise an individual that that will be retained after mastectomy. There are techniques that individuals are working on to try to change that, but currently we can't really say that we can promise that sort of result for an individual. Other things have to do with things like, is an individual interested in having children and nursing those children? So if someone's young, they might want to keep one around in the event that that was something that was important to them, and they could always consider doing something to the opposite breast at a later date.
Okay.
Some people will look at that opposite breast as a means of symmetry. Plastic surgeons will typically tell individuals that they can always achieve their best symmetry if they're doing the same thing to both sides.
Right.
But even in the setting of an individual that may have mastectomy on both sides, your breasts are kind of like sisters or cousins. They're not identical. So most people will have some degree of asymmetry,
Right.
regardless of
Mhm.
what we end up choosing to do.
It's funny that you actually just said that, because so many times in the fitting rooms, I tell people, I've heard many surgeons tell many patients over the years, they're sisters, they're not twins, right? That's the
Yes.
exact, yeah, and that's even regardless of surgery,
Right.
it's both sides. I know, sometimes in the shop here, I'll see reconstruction doesn't always work, unfortunately. I'd say probably the majority of the time it does, but you have those instances where it doesn't. And that's, here where we offer the other side and the external prosthetics. So that way you can, under clothing, still maintain the appearance, of
Absolutely.
symmetry, without anything implanted in the body as
And
well.
there are more and more individuals that are electing to go flat. They have a preference not to do reconstruction.
Mhm.
And some of those individuals may do that just to one side. Some of them may do that to both sides.
Mhm.
There are some individuals that, because of other health concerns, may not really be interested in reconstruction, but in clothing, they might want to look like they are more symmetric
Right.
than they otherwise were. And so that is the benefit of having things like a surgeon like myself ordering an individual to have a prosthetic bra. So a
Mhm.
specialized bra that's fit to their body, that helps them to achieve an improved symmetry in clothing.
Yeah. It's so also in recovery afterwards, you were talking about how, even though it's so close, but not 100%. So after surgery, how often should you be monitored, or what is kind of the post-surgical side?
Great. And that kind of depends a little bit on what an individual had completed. So in the setting of lumpectomy, typically we still want to do things like mammograms for that individual.
Mhm.
And there's still some debates about how often do you do that imaging. At a minimum, an individual should have mammogram of both breasts once a year.
Mhm.
For individuals that may have more dense breast tissue, where it's a little harder to see through the breast tissue
Mhm.
than it might be for someone that has more fatty replaced breasts. The only part of our body that we don't mind being fatty. A fatty breast looks dark gray to black on a mammogram. It's easy to look through because anything we might want to see looks like white. Shades
Okay.
of white are easier to see on a darker background.
Right.
So if someone already has more dense breast tissue, where their background breast tissue is already kind of shades of white on a already shades of white background, then we might recommend that those individuals have more detailed breast imaging.
Mhm.
So those individuals might have a recommendation for things like MRI or ultrasound imaging as a supplement to their mammogram imaging.
Okay.
We generally tend to be the most concerned about an individual's breast imaging and examination within the first 5 years
Okay.
after that surgical procedure. If breast cancer is going to come back, it would typically try to come back within those first 5 years.
Okay.
So for myself, I like to see patients for those first 5 years. And oftentimes for the first couple of years, I might see them every 6 months, just as we're getting used to what the new normal is
Mhm.
like for their examination.
Okay.
Because surgery can influence what the breast texture might feel like. Things like radiation therapy can also influence that. Scar tissue formation over time can alter things as well. So we're kind of getting used to what that new normal is
Mhm.
over time.
Got it. Now, you've mentioned a couple of times lymph nodes.
Mhm.
So people that maybe don't know the anatomy or don't know when do you check lymph nodes, or what do you do if you find cancer there?
Okay, so the lymph nodes that we're typically talking about in the breast cancer arena would typically be in lymph nodes that are in the armpit area.
Okay.
So typically you're talking about kind of the hair-bearing area of the armpit and just below it, as well as kind of underneath the edge of the pectoralis muscle itself.
Okay.
And so, I think that that's honestly not an area that I am examining all the time, unless I'm doing some Saturday Night Live skit, Molly sort of thing from that's dating me right there. But it's not something that necessarily I pay as close attention to unless something stands out, right?
Mhm.
And so I think that certainly when we're washing our armpits, that sort of thing, if something was to stand out, be a little bit different than the other side, then that might cause us to be concerned.
Mhm.
But for individuals, especially that have been diagnosed with breast cancer, or there's a concern, they've had an ultrasound done of their breast, a lot of times the radiologist will also do an ultrasound of their armpit as well. Untreated breast cancer, if it's going to move someplace, would typically go to the lymph nodes first, most commonly,
Okay.
before it could try to go someplace else.
Okay.
So for individuals with invasive cancer that we know has the ability to try to invade into surrounding tissue, we do like to check up on those nodes to help and determine, has the cancer moved to those lymph nodes?
Mhm.
Now, honestly, the removal of lymph nodes is not it doesn't add a day to anyone's life.
Mhm.
But it gives us meaningful, important information to make sure we're treating that cancer appropriately.
Okay.
The number of lymph nodes that are involved influences some of our other treatment recommendations.
Okay.
So it may influence to a degree how many lymph nodes we might remove.
Mhm.
It might also then influence what medications might be best suited for that individual, and or if radiation therapy should include areas of where lymph nodes might be present.
Okay. So over and over again, I'm hearing a lot about time. So if you do find something, you don't wait, right? Don't sit on it. I'll take care of it next week, next month, next year. In the meantime,
So that's a
it
great
could
point.
be building significantly, right? So if
Yes.
you find something, it's important to do something right away.
I will qualify that just a small amount. So for premenopausal women with a new lump, oftentimes I will wait until after that next menstrual cycle,
Mhm.
just to see if it was something hormonally stimulated, like a fibrocystic change. Hormonally sensitive breast tissue caused there to be a cyst or a lump in the breast, but they have their period and then that regresses.
Okay.
Might form new ones elsewhere, but that's another story. But for an individual that's postmenopausal, if they find something new, then yes, I typically would advise that they check in with their physicians. And even if it's a situation, it might take a little while to get in with their doctor,
Mhm.
they may be able to, at a minimum, order some diagnostic breast imaging where we're trying to diagnose why do they have some sort of a change in their breast. So
Mhm.
they might be able to at least get that information back. Now, most breast cancers may take years before they're ever evident on imaging,
Okay.
years before they can form into a lump that we can feel in the breast, and years before it could do something more dangerous to us.
Okay.
So the difference of a month here, a month there, 2 months here, 2 months there, in the grand scheme of things, for most individuals, will not have a huge bearing on things.
Okay.
There's always exceptions to the rule.
Right.
And there are some individuals that have very fast growing processes where days and weeks you can definitely identify a change. That's the exception to the rule. But certainly for situations like that, we would rather see them sooner rather than later, so that we can find out what's going on, educate them appropriately, and make sure that we set up a timeline so that we can have the best opportunity for a successful outcome.
Yeah, that absolutely makes sense. It's it's nice that they have October, right? To kind of bring the importance back to people, to almost force them to think about it again.
Right.
We get so busy in our lives. And I mean, every single day you're working with this. I work with
Right.
this a lot in the shop as well. And it's important all the time,
Yes.
not just October, of course.
Absolutely.
It's great though that it does. Everyone wears their pink, right? And has the support and has it is absolutely fantastic and a good reminder for
Right.
people to really, like you said, pay attention to their bodies. It's everyone talks about self-care now, right?
Yes.
Self-care and
Yes.
take a moment for yourself and do and this is one of those things, like you said, just a quick little not exam, but
No, but just
But
at
just-
least having that awareness. And I think that that does bring up a good point. I think women in general, we tend to be nurturers and we tend to be very focused on taking care of everyone around us, that we may leave ourselves for last.
Mhm.
But it's important to recognize that in order to take care of those around us, we do need to take care of ourselves. So that is an important reminder that yes, self-care does become very important, because how can you take care of others if you're not well yourself?
Right, right. So it's good. But I think I'm gonna wrap up a little bit here,
Sure.
but I wanted to thank you again so much for coming out. It's such a
Absolutely.
pleasure and such an honor. I would tell people, no offense, I hope you never see Dr. Guerra, but
No offense taken.
if you do, yeah, you're in great hands, of course.
Thank you.
And any final words, any last message for all these wonderful
I
ladies? And
Generally
all-
say, be aware, take care of yourself. When in doubt, or if you have any questions or concerns, don't be afraid to check in with your healthcare team.
All right. Thank you everyone so much for tuning in with Breast Talk. Wendy from Broad Garden. It's been nice to see you all.
Thank you.